Hello, everybody. Good evening.
Greetings.
Greetings.
So happy to be here with my friend Sanjay tonight to celebrate his new book and have, I think, a really important conversation around pain, perhaps a conversation long overdue. And I thought the best way to kind of kick this off, it's hard to see the audience, but I think it would be interesting to see a show of hands of people in the audience who experience chronic pain.
Oh, wow. Wow.
So Sanjay, does that match national statistics around?
It might be even a little bit greater. It's about 20% of people, about 50 million adults in the United States who have chronic pain, which when I started writing the book, I didn't even realize it was that high. I take care of patients in pain all the time, so I thought I was looking at a pretty select group. But so this is about 30% probably.
One of the most shocking statistics in the book is, yes, about 20% of people suffer from chronic pain, but that is global, right? Like the stats in the United States are similar to other countries around the world, and yet in the United States, we are responsible for upwards of 80% of pain medication opioid use.
Yeah, that's right. I mean, the idea that pain could be so cultural and the expectations of pain relief are very different in different countries, and that translates to medication usage. So, at one point it's changed. I think this was 2011. We were taking close to 90% of the Percocets in the world. Again, 4% of the world's population. But also, it was kind of everything. We were sort of using sledgehammers for pain. 1.2 million spinal operations were performed. And to give you some context, like in Great Britain, they performed 50,000 in that same year, that 1.2 million, which was 2 years ago. They're about a quarter of our population. So even if you accounted for that, we're doing way more operations, we're giving way more medications. We don't like pain, and we'll do anything we can to avoid it. But that's not, even though pain rates are similar to all these countries, the way we deal with it can be very different. United States versus Japan versus Scandinavia.
Before we venture any further, it would probably be wise to define our terms here a little bit. When you say pain, what are you talking about? What is pain?
Yeah, that's a good question, right? Pain, I think, is one of the most mysterious sensations that we humans experience. It's really interesting. And, Rich, we've known each other a long time, by the way, Rich and I. And sometimes we have these really deep conversations, and I think they're good, important conversations. But, when it comes to pain, it is this very mysterious thing, and I think we'll come back to this, but that mystery of pain is something that I think has frightened a lot of people in terms of treatment. If I can't measure it, if I can't define it exactly, if it's so variable, not just between people, but even within the same person. My pain on a Tuesday could be very different than my pain on a Wednesday. Then I think it's presented a real challenge for the medical world to say, what exactly are we treating and how do we define success? Having said all that, pain is an unpleasant physical and emotional experience. And the emotional part of the definition was something that was added rather recently. Before that, it was pretty much a reductionist sort of definition. Physical pain, that was pretty much it. But the idea that you could not disentangle the emotional component of that was something that people realized, I think, more recently. So an unpleasant physical and emotional experience.
What's interesting about pain, well, there's many interesting things, obviously. You agree, you wrote a book about it, but is that it is this phenomena that defies our capacity to measure it. And we're in 2025, we have extraordinary technology and all of these advances in medicine with diagnostics and scanning and AI being able to evaluate data sets and extract, new kind of therapeutics from that. And yet, pain remains this very elusive concept. To your point, it's this subjective experience that is very confusing to get our arms around and to really kind of like hone down on like what it is and what it means.
Yeah, and I think that sometimes when I was writing this book and I was just going down these rabbit holes thinking about pain, I would sort of arrive at this conclusion that maybe that's just the way it's supposed to be. And we have this deep-seated desire to always attach metrics to things. And when we attach a metric to something, it becomes more important. So like cholesterol, for example, we can measure your cholesterol. And as a result of being able to measure cholesterol, there's a lot of focus on cholesterol. So it's like the ability to measure something drives the importance of it even more than the actual importance of it, which I always thought was an interesting thing. We like to be able to control things within medicine, and measurement's a big part of that. I think with pain, the holy grail is being able to measure it in some way, being able to quantify it, being able to truly understand someone's experience, and then also to be able to measure success. But I'll tell you, if this story about what's going on now in San Francisco with these researchers really blew me away. And these guys, I'll just tell you the background a little bit. They were trying to get at this idea of, can we measure pain? And the way that they decided to approach it was audacious, but they found these patients who had chronic pain, terrible pain, chronic refractory pain syndromes. They're called CRPS. They had people who had thalamic strokes, and as a result of that, had this hemi-body pain, like pain on one side of their body, and just got no relief. So these patients were really, really in a bad place, had multiple operations, all these things. They are the ones who qualified for the trial. They took them and basically put in 2 arrays of deep brain stimulators on either side of their brain, right side, left side, and basically just put 140 different electrodes in, and frankly just listened to the brain for weeks. And to give you context for that, there are about the same number of neurons in the brain as there are stars in the sky. So this would be like basically pointing a telescope up at the sky and just seeing what you see. Now, what the patients would be doing is when they had pain, they would basically push a button or record it, and then they'd go back using big data analysis and say, what did we see in the brain at the time this person was experiencing pain? What kind of energy transfer did we see? And then they would slowly zero in on that and say, okay, every time this person has pain, we're seeing a star way off in the distant galaxy fire a little bit. So let's start zooming in on that star. And they zoomed in more and more on that particular star, and they got to the point where they could actually, when something happened in that star, even before the patient experienced pain, they would start to see that energy change in the star. So they could measure how much of an energy change in the star was happening. And then they could basically give a little stimulation to the star before the person actually ever experienced pain. So think about that. So what we're basically saying is that pain is in the brain. You can find it, you can measure it, you can predict it, and then you can interrupt it. In some ways, it was the perfect biomarker. You actually had it. And this doesn't mean people are going to get brain surgery for pain, but what it has taught us is that all these things are happening in the brain, and they're predictable and interruptible. So I think it's going to pave a whole new path for how we think about pain in the future.
I mean, yeah, that does seem to be a pretty monumental breakthrough. What wasn't said was the fact that there is no central pain center in the brain. Like we have this, there seems to be a center in the brain for everything, and yet when it comes to pain, this universal experience, there is no discrete location within the brain that people like yourself can point to and see when it's activated or not, which is why they had to put all of those sensors, all in all these different places to try to understand. It feels like AI would be quite handy in trying to, hopefully start to make sense of, because I'm sure they're giant data sets.
These were huge data sets, and I think for a long time we believed there was. In fact, we even knew the area. It's called the anterior cingulate cortex. It's a particular part of the brain near the front. And there was a lot of focus on that. There was even these early operations performed in people with refractory pain where they would try and target that cortex and maybe even try and cut it or stimulate it in some way. But it didn't work really well because there is no constant pain center for everybody. It's not in the same place for everybody. So, I think we've certainly learned a lot about it, but we also know that the pathways for pain go through all these different areas of the brain, a big one being memory. So if you've had a pain experience before, and now you're having another pain experience, your brain is immediately evaluating this new pain experience through its memory stores. This is familiar. I've experienced this before. Is it going to hurt? Did it hurt last time? How much did it hurt? Did it leave some sort of toxic force in my body? All these sorts of things. So it's remarkable how quickly the brain starts to evaluate all of that. And it's also, by the way, evaluating what the weather's like outside, what kind of mood you're in. Are you depressed? Do you have anxiety? Did you sleep well last night? Do you have a lot of inflammation in your body? All these types of things. It's doing this all in a split second and then making a decision, yes, I'm going to make this hurt. And in an acute pain situation, the reason that it's making it hurt is because it doesn't want you to stub your toe again or step on a Lego or do whatever. That's that acute pain learning. That happens really fast, but they can get it wrong. And if you really expected that stub toe to hurt, it will hurt more because that's what the brain is doing. It's basically processing your expectations and translating it into your experience. This is part of the reason I say it's so mysterious, but so fascinating as well.
Very complicated and mysterious, but two things jumped out to me in what you just shared. The first thing, which is that pain is generated in the brain.
Yeah.
And, just to really sit with that for a minute, because I think we think if we stub our toe or we scrape our knee or have a serious pain, that pain is being generated in the locus of the injury. And in fact, the experience of pain is occurring inside our minds, which is the mind bender right in and of itself. And then everything you said basically, to me, translates into this idea that pain is essentially a subjective experience.
All pain is in the brain. And 20, 30 years ago, when there were authors, 40 years ago, John Sarno wrote a book about back pain. And he talked about the fact, he was getting at this idea, I think back then, that people referred to it as psychosomatic. I think for decades, this sort of got a bad rap. In fact, if you read Sarno's obituary in the New York Times, basically it says that he was considered both a prophet and a pariah for his beliefs about pain. But I think what he was trying to get at was this idea that the pain is in the brain. And if the brain decides you don't have pain, then you don't have pain, it is a very meta thing to sort of consider. But the flip side of that as well is if the brain decides you have pain, then you have pain. And it can even occur in a limb that no longer exists, which is phantom limb pain. And I think the data around phantom limb pain taught us a lot about this because the brain is the ultimate regulator of all this, both in terms of not having pain or diminishing your pain or creating it and worsening it. And a lot of that is very dependent on your expectations of pain. A lot of that is dependent on things that seems totally arbitrary, adverse childhood experiences, again, what you had for dinner the night before, whether you had a tough call with your mom, whatever it might be, those things can greatly determine what your pain experience is going to be in the moment. That's all coming from the brain.
There's something very empowering about that. It
Right.
gives all of us agency to develop a relationship with our own pain and go on a journey, to try to find ways to heal it or ameliorate it, right? But when you bring up Sarno and this idea that it is this subjective experience, it's also a very confronting idea, hence the sort of pariah label with someone like Sarno. But it gets to the mystery and the complexity of all of this. Like, if we do have agency to develop this relationship with our own pain and figure out practices and modalities for having a different experience with it, that is incredibly encouraging. And that's really the message of your book is a very optimistic, positive one. I mean, I feel like that's the real thrust of what you're trying to express here.
Yeah, I think for sure. When I heard this, when I really started to do the deep dive into the research, I looked at that as an opportunity for more potential relief for people. You've identified where that pain is in the brain, and all these things play a role there. You know this well. I mean, you've gone through this, and I don't know how comfortable you are talking about it, but I will say it's probably pretty interesting for you to sort of think, when I had pain, what ultimately got me through some of the toughest times. And I think one of the things that you and I've talked about, which I found very fascinating, was, do you want to tell your story a little bit?
I mean, sure, I'm happy to.
I think it's instructive.
I had a spinal fusion surgery about 4 months ago. I had been dealing with chronic lower back pain for more than a decade.
2012.
Sanjay's aware of this. I would hit him up from time to time.
I was his guy.
I was showing Sanjay my scans, my MRIs, I think it was 2 years ago, and you were like, yeah, I think you need to So essentially, I'm also an athlete, and I sort of trained through chronic pain and just was doing everything in my power to avoid surgery. And I live in Los Angeles, and if you're in Los Angeles and you tell somebody you have some kind of chronic pain, God forbid a lower back issue, everyone will tell you that you have to go see their guy. Like, everyone's got a guy, and there's a lot of, savior complexes out there. And so I sort of wandered in the wilderness I had my own exploration. Many of the types that I explored you talk about in the book. Like, I saw all kinds of interesting people who tried to help me, and some were helpful, some less so. But I was cultivating this relationship with my own pain. In my scenario, ultimately, surgery was an inevitable conclusion for the condition that I had, which was a grade 2 spondylolisthesis. I had, a vertebrae that was compressing the nerve roots and out of whack, and the only way to fix that really was through surgical intervention. And so now I'm in this healing process, and that's been a journey with a different kind of pain. And the way that I've approached it, and I'm curious what you think about, and when I was in surgery and in the aftermath of that, the only questions I got about pain were, how's your pain from a scale of 0 to 10? Like, that's it. Everything else is super high tech. But when it comes to pain, that's all they got, which is crazy, right? But in my life experience, and I'm just speaking for myself, pain has always been my ultimate teacher. Like, all of the transformations and changes that I've made in my life have been a consequence of pain trying to tell me something, and me refusing to listen, and the pain growing more and more intense until whatever pain I was experiencing exceeded the fear of making the change or doing something different. Like, that was the fulcrum twist. And in this healing process that I'm in right now, I'm really intentional about my mindset, and I'm approaching the challenges that I have right now as opportunities. Like, oh my God, I get to wipe the slate clean and start over, and what would it look like if I could rebuild my body from the ground up and do it right and make it bulletproof as I go into my older years, or I can relearn how to run and learn how to do it the correct way. Like, how cool is that? And how often in your life are you in a position where you have to stop everything you're doing and you can't do anything else except be with yourself? And life's greatest truths are found only in the present moment, but we distract ourselves. And here I have this amazing opportunity where the world is giving me permission to do that. And I don't want to let that opportunity pass without learning those lessons. So whether it's an obstacle, an emotional pain, a childhood trauma, an adverse childhood experience, these are all packed with lessons for those who are earnest enough and courageous enough to walk towards them and engage with them curiously rather than avoid them. And I think I don't mean to be insensitive to people who have been in a car accident and something happened to them that so this is my own experience, but we have a choice. Like, we can take an opioid and check out, or we can look at it as an adventure, an exploration for our own personal growth and evolution. And I think that message, although maybe it's not stated overtly in your book, is the message that you're making. Like, rather than take the pill, here is an opportunity for growth and because all of the modalities, and we'll get to those, like whether it's mindfulness or meditation or breath work or, just a visualization practice or all of these other things that you talk about in the book, like these are all growth opportunities that I think personally more of us should be doing more of the time.
I love you, brother. That was really good. And how are you today, though?
I feel great. I'm at the 92nd Street Y talking to Sanjay Gupta. Thank you. I just started PT. Like I'm 4 months in, and I only started PT a week ago. Like all I'm allowed to do really is walk, and I have a couple little exercises that I can do. But I went on an amazing walk on the waterfront this morning, and it was the first day of school, and there were so many high school kids out, and they were all excited, and it was a beautiful morning. And yeah, I have discomfort. The surgery was successful, so a lot of the pain, that I was experiencing before is gone. But my left foot is entirely numb, and I have numbness up my leg, and I could focus on, like feeling fragile, and like I can't really bend over. It's very difficult to put my shoes on. I think we're storytelling animals, right? And we construct stories about whatever's going on. And again, I'm always drawing my awareness to the story that I'm telling. Is it a negative story? Is it a positive story? Because I could create a whole victimology about like, I can't do this and I can't do that. And if I can't go and run 100 miles, then I don't know, it doesn't feel like me. And I can lament that and be resentful, or like I shared earlier, treat it as a positive experience, as an opportunity, right? And so that's what I'm doing, and because of it, I get to talk to you about pain here, like talk about mysteries, the fact that we're here doing this together. So I'm doing great. That's the answer to it.
That's fantastic. Yeah. I love hearing that. It's interesting, and I did want to talk to you about your pain because many of you may know, but Rich is also an Ultraman. That's how we first met, I think around the time we first met. You'd just done the Ultraman. So to me, you're always this larger-than-life figure in terms of athletics, in terms of fitness and things like that. And I think you and I both wondered a bit when you were having these back problems, if you got surgery, was that going to sort of propel you through your recovery or not? I mean, I think the general gist always is like, look, if you're that fit as you are, going through an operation like that, it's going to really be beneficial for you for your recovery. And what do you think of that?
I think that brings up an important subject that you talk about in the book, which is identity, and back to stories, the stories we tell ourselves about who we are and the attachments that we have to them. And in order to have a productive, constructive experience with this surgery and with the pain that I was experiencing then and that I'm experiencing now, I had to accept and surrender the identity of like, oh, I'm this athlete and these are the things that I do. Like, maybe I'm not anymore. And that could be a source of suffering, or it could be an opportunity for reinvention. I'm 58 years old. Like, I don't have anything to prove as an athlete anymore. And I think the growth that I've resisted that would probably be most beneficial for me is to stop and look inward and engage in the present moment rather than using fitness or running to always run away from anything that's making me uncomfortable, if that makes sense.
That's really interesting.
Because pain, to me, Sanjay, I know that your focus is on chronic physical pain, but the pain that has been most difficult for me to master and transmute and overcome have been like emotional pains, and that's what's interesting about pain. We have this one word that applies to all of these different, very varied, aspects of human experience, but if you're an addict in the throes of addiction and you're craving, like that's a pain, and there's a physiological aspect to that that's very different from lower back pain. But is it really all that different? It's a subjective experience that you're having, and that applies, I think, to grief, sorrow, depression, and thinking about pain as this holistic sort of thing and a bilateral relationship between the physical and the mental and the emotional.
There is no question that probably using just one term, pain, is shortchanging the conversation. But at the same time, this idea that loneliness, for example, like we were talking about earlier, when you're looking at the brain and people feel physical pain, they're feeling physical pain in the same place that you would actually feel physical pain. It's not only do they feel it, you can see it represented in the brain. But what I thought was interesting is that acute pain, a pain that's occurred in the moment, versus chronic pain, which is generally defined as pain that has lasted 3 months or longer. For some people, it's decades. There's very little overlap in the brain in those two things.
Interesting.
Acute pain and chronic pain. And so in fact, when I was writing the book, I almost thought, I wish there were different terms for this. Acute pain is almost a distinct entity than chronic pain. So again, acute pain is something that we're probably all going to experience in our lives. But for some people, it becomes chronic. And I think that is the real question. Like in your case, you had pain since 2012. You clearly were in chronic pain. And you needed an operation. I saw your scans. But the idea that your chronic pain needed to be treated differently than your acute pain, I think is really important. And what does that mean? As someone said to me, a guy named Robert Jensen at Mayo Clinic, he said, chronic pain never occurs in isolation. It always comes with baggage attached. And that baggage can be a variety of things. Again, it can be depression, anxiety, whatever it might be. But so often, when we're treating chronic pain, we are treating it like acute pain, even though they are nearly distinct entities. And the acute pain, probably besides being represented differently in the brain, could be treated just simply with the operation, whereas chronic pain needs to have these other things, this other baggage addressed to be able to get to the same level of relief as with acute pain. It's complicated, and we don't think that way generally. Again, this gets back to your first question. Instead, we would give an opioid. Instead, we would do an operation instead of also addressing the baggage that comes with chronic pain. And I think part of that is because there's stigma with that baggage. And John Sarno writes a book, and half the population calls him a pariah, whatever it might be. But I think we are getting to the point where in ERs, if someone comes in with chronic pain, they might see a psychologist at the same time they might see a pain doctor, which I think could be really, really helpful.
Talk a little bit more about what you mean when you say baggage. Are you talking about like emotional stuff, like depression, anxiety, things like that exacerbate the experience of pain?
Yes, but it is truly a bidirectional relationship. And I'll use the example of sleep to sort of make this point. I think for most people who have pain, a lot of people in this audience, and also have poor sleep, the general sort of guidance I think that they've probably heard is if you can get your pain managed better, it'll probably improve your sleep. And I think that fundamentally makes sense. But if you start to look at what the data really shows is that people who instead focused on their sleep first, they were able to have much greater success in managing their pain. So that is the bidirectional. Yes, the pain can exacerbate your sleep problems, but poor sleep can exacerbate your pain. Same thing with depression, anxiety, all these other things.
Yeah, you said something really interesting about sleep, which was that, I don't know if I'm going to get this right, but it was something like poor sleep is a greater predictor of pain than pain being a predictor of poor sleep.
That's right.
Did I get that right?
You got that right.
Yeah.
That's good. Hasn't affected your memory.
Which is wild, right? Because you're like, well, I didn't sleep well because I'm in pain, right? But actually, if you could sleep well, you would have a different experience of pain. So it's a vicious cycle sort of thing.
But I think in a monotherapy culture where we want the quick fix, again, going back to your first question, I want to just be able to fix both problems at once. I'm going to focus on the pain. That'll help my sleep. And again, I get that. I've had pain episodes in my life where I was sort of thinking the same thing. And there's some wisdom there. But the idea that all these things are bidirectional because the brain makes it that way. And if the brain is now processing a pain experience in someone who's gotten good sleep, it's likely to say, hey, this is a more relaxed state, whatever it might be. I'm going to mitigate the pain as a result of the better sleep. If someone's inflamed because of depression or anxiety, addressing those things can mitigate the pain, which isn't, I think, how we've thought about things very much. We've always thought about it only in a one direction sort of way.
On the empowerment aspect of this, thinking about the bilateral directionality of all of these different this interplay, right? This dance between emotions and our thoughts and our experience of pain, and thinking about strategies for better mastering it and the empowering things that we can do. Can we talk a little bit about neuroplasticity? This idea that neurons that fire together wire together, right? And we can change these patterns, but there's also a less discussed negative aspect to this.
That's right. That's exactly right. This was really fascinating. I was spending time with these neuroscientists, and one of them said to me, made this sort of offhanded comment that people who have really good memory are more likely to have chronic pain. I thought, what is the relationship here between memory, really good memory, and chronic pain? And they went on to say that when you think about chronic pain, in many ways, from a neuroscience standpoint, it is sort of like a memory that cannot be extinguished. That was the exact language that they used, memory that cannot be extinguished. In some ways, it sounded like they were describing post-traumatic stress to me. And chronic pain does have a lot of components that are similar to post-traumatic stress. You don't have anything that should continue to cause you pain past 3 months or 6 months, whatever the number may be. So why do you continue to have pain? It's not like you continue to have an injury, so why is the pain still there? The lesson has been learned. But you stubbed your toe, don't do that again. Why does the loop keep getting played over and over again? That again is one of the great mysteries. For some people, they just tend to play that loop over and over again. And interrupting that memory loop is actually one of the strategies to try and combat chronic pain. It's a totally different way of thinking about things. But what do we do instead? Powerful pain medications, procedures, things like that. Again, I want to be clear in your case, and I happen to have looked at your scans. It was very different because you had an anatomical problem where your bones were actually slipped one on the other, and as a result, they were pressing on the nerves that was causing your pain. But for people who have lower back pain with no identifiable anatomical problem, oftentimes it is a memory that cannot be extinguished. So focusing on that makes a huge difference. That is a component of neuroplasticity. You've just started to fire those neurons together, and now so you kind of almost have to break that loop.
Right, so you're reaffirming this story. And
yes.
It becomes entrenched. This memory is constantly being resuscitated, and then it becomes this intractable thing where you can't overcome that enough to have a different experience of this pain that shouldn't be bothering you in the way that it is.
And the thing that you said about your own experience was, when we were talking about this, at some point you realized that the pain that you continued to have was not some persistent toxic thing in your body. The anatomical problem had been fixed. But you were still sort of wincing, like, I'm not sure if I can bend this way, I'm not sure if I can do these things. At some point you became convinced that you could, and that there wasn't this thing that was continuing to disrupt your spine, and that knowledge helps break that memory loop now.
Yeah, I mean, what Sanjay's referring to, I mean, it was a crazy experience right after I had my surgery and the sort of day 1, day 2, day 3. I'm still in the hospital, and I'm Mr. like endurance athlete guy, and I thought like, well, I have this, like, I'm gonna be out of here. Like this is gonna be no problem. And I had an extreme pain experience, much more extreme than the typical patient, which was confusing to me. And I ended up staying in the hospital like a day and a half longer than the average patient for my procedure. And my surgeon at some point had to sit me down and give me a hard talk like my dad or something like that. And he went through this whole thing about the subjective experience of pain and how I was having an extreme version of it, but I had to push through it to overcome whatever neural pathways were, creating that experience for me, to prove to my brain that I wasn't in danger, because I couldn't sit up, I couldn't do anything without just extraordinary pain, because I believed that my brain was trying to protect me. It's like, oh, if you move that way, you're going to break, right? And once I could change the story and say, you're not broken, you're actually more stable than you were before, and yeah, it's going to hurt when you move that way, but you're not harming yourself. Very quickly, that experience, the intensity of that experience dissipated significantly. And that was a remarkable thing. And when you first reached out to me about having this talk, and you were like, how was that? And I said, I learned so much about the subjectivity of this experience because of what I just went through. And you were like, oh, that's like exactly what I talk about in my book. But it was profound.
Our expectations and our experience are inextricably linked. This was a teaching for me. You know, there were all sorts of teachings, but this idea that how we come to expect certain things based on all the things that we've talked about, past experience and all that sort of stuff, will dramatically affect what our experience is going to be. So you no longer expect, because you were told by your surgeon in that tough talk that, look, you're fine. I mean, we've fixed the anatomical problem. So you shouldn't have that same sort of chronic pain that you had before. You were expecting to continue to have it. You were worried that you're going to harm yourself bending a certain way. He flipped your expectations, and that changed your experience. It's pretty profound stuff. You know, the other thing that someone said to me when I was working on this is that, you know, there's a difference a little bit between suffering and pain. In fact, the equation that they sort of attach to it is that suffering equals pain times resistance. The more that you're resisting it.
Jon Kabat-Zinn.
Jon Kabat-Zinn. Yeah. Good. You actually read the book. That's impressive. The Jon Kabat-Zinn. Suffering equals pain times resistance. And so the idea that the more that you're resisting this, it's going to increase your suffering. The pain is constant, but the more that you resist it, it's actually increasing your overall suffering.
Speaking of resistance, you mentioned to me earlier today that you were reluctant to write this book. You had some sort of, I don't know if they were misgivings or concerns about diving into this topic. Can you talk a little bit about what that was about?
Yeah, you know, first of all, I never have a real sense of what is already out there in terms of these books. You know, I knew that this was a fascinating topic, but I wasn't sure where we were sort of in terms of people's interest in this. And also this idea that the opioid epidemic had really hijacked the conversation for a long time, for a quarter century. If you talked about pain, it probably had something to do with opioids and the opioid crisis and addiction and all these different sorts of things. So, and I didn't want to write that book. I felt like that had been done. And then there was this idea that I knew where this research was going was really showing how much of pain really was in the brain. And I knew that that was a provocative topic. People, the conversation often goes to this idea that you're saying it's all in my head, and it's minimizing or diminishing people's pain experience, and that was not at all my intention. But I was worried that it could get perceived that way. So those were some of the misgivings. But I think what I was really sold on when I started to write this was that there was all these other modalities for treating pain, some of which were things that have been around for a long time. You know, I spent time at this emergency room here in Brooklyn, Maimonides, and they created these what they call opioid optimized shifts. They used to be called opioid free shifts, but opioids as a last resort instead of a first resort. And you know, it's interesting when you talk to the docs there, they're taking care of everything. This is a fascinating hospital, by the way. They speak 120 languages there, so super diverse population of people, very busy, level 1 trauma center. People come in for all sorts of things. They've been shot, they've been stabbed, they've broken their hip, they have kidney stones, whatever it might be. Pain is often what's bringing them there. And they went to this opioid optimized model. And all of a sudden, they started doing things like nerve blocks, for example, for a broken hip. I saw a 76-year-old guy who came in with a broken hip, absolutely did not want opioids, it was last resort, and got a nerve block. And his pain score went to a 0, and he never required opioids. I saw a woman who came in with bilateral knee pain who got a dose of virtual reality. They put on virtual reality goggles. Some of this sounds silly, maybe, to people, and yet her pain score dropped from an 8 to a 3 within 20 minutes. She was on a nice trip to an Indonesian beach, some in her virtual reality. Ketamine. Ketamine is something that people have heard of. They've heard of it as a club drug or as an anesthetic going back to Vietnam. It is now being used in ERs to treat acute pain. Point being, Rich, that opioids, they hijack the conversation not only among patients, but even among pain docs who believed that if I don't give patients opioids, They're not going to be satisfied. Satisfaction scores will drop for the doctor, for the hospital. And what they found as they started these opioid-optimized programs was that it was quite the opposite. There was a reluctance for people to jump into opioids as a first-line therapy. And with these other modalities, patients were quite satisfied with their pain scores. And I think that really got me interested. It wasn't a new story. It was an old story in some ways. It was a pre-opioid story, but it was a story that we had forgotten. And to just give you some context on how much opioids have hijacked the conversation, the first new pain pill approved by the FDA was approved this year in March.
In like 25 years, right?
Since 1998, Celebrex was the last one. Chronic pain is the fastest growing condition in America. It's faster than diabetes, than cancer, than dementia. We talked about the fact that 50 million, 21% of the population has chronic pain. In any given year, the FDA will typically approve 40 to 50 new drugs. Since 1998, for the fastest growing condition in America, there had not been a single new drug approved. And I think part of it, again, is because we became this monotherapy culture that liked the sledgehammer of opioids. I don't know if we liked it, but that's what happened. So we were throwing a lot of those types of medications. And by the way, this new medication, suzetrigine, it's called, works in a totally different way than opioids. It's not non-addictive. It's actually working by blocking certain sodium channels, so stopping the pain transmission from getting to the brain in the first place is basically how it works, versus opioids, which really kind of sedate the brain.
Essentially, the book flips the paradigm upside down. Rather than opioids first, and then we'll look at all these other things. You're basically saying a lot of these mind-body modalities should be the first line of defense.
Yeah. I mean, look, the body can do a remarkable job of healing itself if we allow it to. This even gets into basic things like a sprained ankle, for example. When I was working on the book, I came across these researchers who were trying to answer the question, who is more likely to develop chronic pain? That was the basic question they were trying to answer. And they were measuring all these things in patients. They were trying to look at their biometrics and their overall injuries and anything else. And they came across this really interesting finding, which was that the people who had the lowest levels of inflammation at the time of injury were the most likely to have chronic pain. Okay?
Yeah, that's the opposite of what you would think.
The opposite. And what do you do for a sprained ankle? You rice it, right? You rest it, you ice it, you compress it, you elevate it. What are those things designed to do? They're designed to decrease blood flow to the site of injury and decrease inflammation. And yet these studies show that if it's chronic pain you're trying to avoid, you need that inflammation, actually. People at the lowest levels were the worst off 3 to 6 months later. So we've been doing these things in the pursuit of immediate relief, and I get it, you know, you want to rest that, but the idea that instead of RICE, which is the acronym, we should be advocating for MEAT, which is mobilization, exercise, analgesia,
There's
and
a low-hanging fruit joke in that, but like...
Meat instead of rice.
Yeah, there's a lot of counterintuitive things like that are fascinating. Well, to be continued.
All right.
Ladies and gentlemen, Dr. Sanjay Gupta.
And Rich Roll.
Thank you.
Rich Roll. Thank you.
Thank you for showing up tonight.
Thank you for coming.